Don't forget the venous system. There are so many young patients out there suffering from post-thrombotic syndrome, from abdominal pain, swelling of the limbs. Please evaluate the deep venous system as a potential issue for these kind of clinical problems these patients might have. We now have, especially in the European market, a lot of dedicated venous stents on the market. That's right. Also in the United States, a handful of stents are now approved. That's for sure. We know that we have different needs in the iliac venous system. The more proximal we are, we need radial force crush resistance. The more distal we treating, like under the ligament or in the femoral, we need flexibility. So it's good to have different options available. And for the IVC, for the vena cava, I don't see at the moment an approved venous stent which is really dedicated for this area. There's some new stents now coming for this area, so it's good to have innovations here in the future. Unfortunately, there are a lot of patients out there who are suffering from occluded iliac veins, meaning having a post-thrombotic syndrome. They are not even evaluated if a recanalization procedure might be an option for them. So I think it's important to raise awareness here to analyze if this patient can benefit from an iliac vein treatment. So my clear message is don't forget the iliac vein lesion. Don't think only superficial. Think of the deep venous outflow obstruction disease. We can help these young patients to treat their post-thrombotic syndrome. In the past, we used thrombolysis a lot. CDT, catheter-directed thrombolysis, was the standard with a lot of problems, safety issues, bleeding complications, intensive care unit, surveillance of these patients. Of course, and this is also an economic problem in the past. We have now different devices on the market which follow a mechanical thrombectomy approach, meaning you don't need any additional thrombolysis in these patients based on the existing data we have for these new dedicated devices. And with that, we can treat these patients fast, safe, and very effective. So the patient do not need to stay very long in the hospital, do not need any intensive care unit surveillance. And this is, I think, an approach we should definitely follow. We need to learn which device is in which indication the best one. This is something we need to answer in prospective trials, but I definitely see a clear advantage now with these new mechanical thrombectomy devices. Better you can't really say. They reported a safety difference between mechanical thrombectomy and these echoes-driven therapy of pulmonary embolism. So we need to wait for the full data set here and try to answer what really makes this difference. So at the moment, I must say, I can't really understand this difference, how a mechanical thrombectomy should actually create more bleeding complication than a local thrombolysis therapy. But please, we need to be objective here and need to wait for full data analysis, and then we can discuss this topic. These patients with acute and chronic venous disease are suffering. So we need to definitely take out the thrombus and treat the underlying disease like a Medterner or obstruction problem. This definitely can only be done with, for example, intravascular ultrasound. So you need to have an intravascular ultrasound in your lab to really identify where the underlying disease of this DVT is coming from or what is the reason for that. So you need intravascular ultrasound. This is an investment, and without intravascular ultrasound you can't do it. And a second point is you need to have different devices available. Not every patient is the same, not every DVT is the same, not every PTS patient is the same. So you need to be prepared for bailout scenarios. You need dedicated stents. You need to have stents with high radial force, more flexibility. Again, an investment point. So you have to invest in a venous care service. And before you start with deep venous disease treatment, you should answer if you can really make this investment. Sometimes you only have one chance in a patient, only one shot in a patient which really needs to be successful. If you fail, then it means follow-up intervention. It could even mean that you are not able to recanalize an occluded stent in the future. So be prepared for bailout situation, do investments. It doesn't mean that you need definitely to prepare a venous care service, also with the follow-up. So a lot of things need to be done to really take care of patients with deep venous outflow obstruction.